Welcome. I'm going to give it just a few minutes while people kind of start trickling in and get connected to your sound. Nick's already dropping in chat welcomes. We are so excited for session 4 of season 2 of Power. For those of you that have been here before, thank you so much, and we're excited that you're back. And those of you that are new to Power, this is the adolescent and young adult program for oncology, workforce education, and resources. This is a series that was developed from the AYA Oncology Education Working Group that really did a study identifying that there is not a lot of education given to trainees and residents and fellows in that early education process. And so we were approached at Elephants&Tea to partner on this amazing initiative to bring education to those that provide care in any capacity to AYAs dealing with cancer. So our entire mission is really to provide oncology trainees with high yield education and resources to improve care delivery and really outcomes for AYAs diagnosed with cancer. And so these sessions bring in an amazing expert on a topic that is really unique and special and deals with the challenges that this population faces. So if you are not familiar with Power, please make sure you check out our website, and I will drop that in chat in just a minute. But it is an absolute library of all of our previous sessions that have been recorded, the schedule of upcoming sessions for the remainder of the year, as well as kind of landmark journal articles and resources that really work to supplement what our amazing speakers are talking about with each session. So please make sure you visit the website to check out what we have there. A little bit of housekeeping. I don't think I even introduced myself, but my name is Kayla. I'm the Senior Director at Elephants&Tea. We will get kicked off in just a second, but the housekeeping I have is this is a webinar, so please make sure that you ask questions of our speaker. They really are here to give you the opportunity to connect with an expert in this topic. So there is the Q&A at the bottom for you to utilize, and we will make sure that we have a wonderful discussion at the end where we can really kind of dive a little bit deeper into some of the questions that we might have. I also need to take a moment to thank our sponsors for the series, which are the I'm Not Done Yet Foundation and AZI. And I am especially grateful to also acknowledge Walgreens, who is sponsoring this amazing session today. And so I also just briefly wanted to highlight Lolly Havern, who is from Walgreens and will be speaking a little bit about the services that they provide. I lost your title for a minute. There it is. Lolly is the Director of Clinical Pharmacy Strategy at Walgreens. We have had an amazing partnership with Walgreens for several years, including creating a cancer and fertility special edition for the young adult population. And so I would love to pass it to you, Lolly, to share a little bit about all that you do.
Thank you so much, Kayla. As Kayla mentioned, my name is Lolly Havern. It is a pleasure to not only sponsor this webinar, but really be here with this amazing group of people. So thank you for the time. Thank you, Elephants&Tea, for really all of the great work that we've been able to do over the years. I did want to highlight, so Walgreens has actually been in the fertility preservation space since about 2012 as the sole dispenser of Ferring's Heartbeat program, which provides free medications for patients that are undergoing a fertility preservation cycle. But it really wasn't until 2 to 3 years ago when I started working with you guys, when I met Dr. Fair, that something sort of clicked where we need to be doing more as pharmacists. So I'm really happy to share that because of this collaboration, we started an intervention at Walgreens with all of our new to therapy cancer patients and asking them if they've had a fertility preservation conversation. So we know oncologists are, the first stop, but sometimes they may be overwhelmed. It might just not be the right time. And so we just felt that having this extra step at the point of dispensing, now we're not holding treatment, we just give them the option, but really proud to say since we started back in 2023, we've screened over 1,000 patients. Sadly, that number, it's like 20 to 25% are still going for that referral. So we've partnered with a network of clinics that's willing to see a patient same day. So the last thing we want to do is delay treatment, but we definitely want to make sure that that patient has a choice and is able to talk to a reproductive endocrinologist. And so really, I just wanted to say a big thank you to this team, especially Dr. Fair and Elepants&tea. Because of you, this really is how the intervention got started at Walgreens. Right now, we're screening 18 to 50, so we're hoping to lower that age and really get some of those peds in there. But baby stuffs, as we like to say. So again, just wanted to say thank you for the time. Thank you for everything that you do. And I will be on the webinar. So if anyone has any questions for me around medication resources, especially if you are going through treatment, please let me know for either oncology or fertility. And I think I'm going to pass it on to Mike. Thanks, everybody.
Yeah, thank you so much, Lally. Thanks for all that you and your team do to support patients. I think at the end of the day, we're all here together to make sure that patients get optimal care. And there's many different opportunities for us to increase access to care and increase access to knowledge as to what's needed when an AYA is diagnosed with cancer. So on that note, it is really a pleasure and a privilege to introduce our speaker today, Dr. Doug Fair. So full disclosure, Doug and I know each other quite well through the years. I have about a 3-page introduction, which I'm not going to do because I know Doug so well. And you know, he is a wonderful friend, colleague, and expert in AYA cancer care delivery, and specifically an expert in oncofertility care and access to care. So Doug runs the largest AYA program in the state of Utah. I've always been impressed just thinking of what Lally just said of their outreach across the state, such a large geography to make sure that patients get access to necessary AYA care, including oncofertility. I'm going to cut my introduction short because I do not want to eat into the time that Doug's going to share with us. I would highly encourage folks to please write down questions, put them in the chat, and also come off mute at the end. I don't know if that is allowable in this format, but please at minimum put questions in the chat. We'd love to have an active discussion afterwards. So thanks, Doug, for coming to present to the group. Looking forward to your talk.
Thanks, Mike. And thank you to Elepants&tea and Lolly, Walgreens, Kayla, and the whole team for inviting me to speak with you today. It's really, just trying to share my screen here. Here we go. It's really a privilege and an honor to speak with you today. Really appreciate your time and attention. I know everybody's got a lot going on, so I really appreciate you carving out some time to talk about this really important topic that I'm very passionate about, and everyone I think on this call is, which is serving AYAs and specifically oncofertility. So with that, I think Mike mentioned I'm at the University of Utah at Huntsman Cancer Institute as our adult academic institute, and I also work at Primary Children's Hospital, our pediatric academic program here. So I have no financial disclosures. Really today, I want this to be a really practical talk where I hope you take away from this just, you know, a little bit about the scope of oncofertility, but really have some practical takeaways about how to do a consult and what to think about with the consult. But I realized I didn't pause to make sure everyone's seeing my screen okay and hearing me. Okay, I got a thumbs up. Awesome. Okay, great. So yeah, so I think the first goal is to really state, it might be the obvious, but how important fertility preservation discussions are to AYA cancer patients, and provide a little bit of data context there. Also describe the scale and discuss why there is a failure in providing fertility preservation services to 100% of AYAs. And until we get there, until we hit that goal where every pediatric, adolescent, young adult with cancer gets this conversation, we have work to do. I'm then going to review the fertility preservation methods for men and women. I'm going to describe the challenge of cost in fertility preservation because it's a big barrier, and it's something that I think we all need to know about and we work on as a system, but also those who are providing consults, I think, need to know this. And then we'll talk about how to perform a fertility preservation consult, what type of things to think about, and then review resources for patients and providers. And then we'll have a Q&A, which I'm really excited about. Okay, perfect. So the importance of oncofertility, fertility preservation consults, for those who are in the AYA space, Salika Jawad is really a hero. She became known on the national scene when she started describing her journey with cancer when she was diagnosed. I think she was 23. And she did this incredible series for the New York Times entitled Life Interrupted, where she really chronicled in real time what it was like to be a young adult and go through cancer therapy. She then wrote a New York Times bestselling memoir entitled Between Two Kingdoms, a memoir of life interrupted, which is just an incredible read. And I just can't recommend more or highly enough. And I want to start off this kind of talk by quoting Salika. And this comes from chapter 8 of that book. And the title of the chapter is Damaged Goods. She writes, "Cancer is an emergency, and oncologists are the first responders. They are trained to beat it, and everything else must take a back seat. But no one on my medical team, as the treatment plan was drawn up, had mentioned infertility as a potential side effect. The absence of communication on something so important felt like a breach of trust early on in our patient-doctor relationship. While my medical team was intent on saving my life, preserving my chance to be a mother someday hadn't seemed to be on their radar. It was my first indication that no matter how brilliant or compassionate my doctors might be, I would have to be proactive and learn to advocate for myself." So, do patients want to discuss fertility preservation? Absolutely, absolutely, absolutely. It's a primary concern for survivors. Survivors wish to have biologically related children. They, in fact, place an increased value on parenthood because of their experience with cancer. And some have described loss of fertility can be as difficult to face as cancer itself. And I also just want to put this in the context, we're talking about Oncofertility Day, but it really has to be appreciated that AYA, there's so many disruptions, so many challenges that are being in AYA. Between a cancer patient is between this illness and death and this wellness and living, or between two kingdoms, as Salika puts it. A young adult is between a child and an adult. It's really in this liminal space of a lot of developmental important milestones are happening, and survivorship of being between a cancer patient and not a patient. And really, fertility is one of many really important life disruptions for AYAs, but one that we have to kind of think about up front, which is just really, really challenging. This is a pictorial which kind of just shows the journey of a cancer patient, and just to give some context and the numbers that we're dealing with. If you take patients in the United States diagnosed with cancer, all that are less than 39, and of course, patients in their 40s might still think about family building, but AYAs, as you probably know, in the United States, we consider age 15 to 39 a diagnosis, pediatric between 0 and 15 or 0 to 18. In the United States, 120,000 patients every year less than the age of 39 are diagnosed with cancer. So that's a big group of patients, and many of them are going to undergo therapies that are gonadotoxic or could affect their fertility. One of the really positive things, and why this is such an important thing to think about all these issues after cancer, is because our cure rates have really increased over the last few decades, where survival for AYA pediatric cancer is north of 80%, really north of 85%. So it's incredible. So it is also a burden on us to make sure that we are thinking about life after cancer for these patients. And as I said, one of the really important ones that survivors tell us, that AYAs tell us, is fertility. This is the same pictorial with two arrows, and I wanted to show this because I think it's really important to think about fertility preservation at two time points. One is before cancer therapy starts, and that makes it a challenge because there's so many things going on when a patient is diagnosed, emotionally, logistically. Obviously, every young adult expects themselves to be healthy and do not expect to get this cancer diagnosis. So it's a really hard time, and that's the first arrow on the left. And then that arrow on the right is after they have finished therapy. And I think this is also a place where we're really missing, and of course, survivorship really needs to be improved in this country for adolescents and young adults and all cancer patients. But there is a real opportunity for a lot of patients where we might have affected their fertility, but the door isn't closed yet and we have opportunities. But again, if we're not thinking about it as providers, as a system, to think about fertility preservation for patients who are in their survivorship and after they're done with therapy, then we're going to miss it. And there are lots of reasons why patients might not have that conversation up front, or they had the conversation and they decided fertility preservation at the time wasn't for them, or medically it wasn't the right time, but there's an opportunity afterwards. So I want to emphasize there's really 2 times to think about fertility preservation. I just want to read you the guideline statement from the American Society of Clinical Oncology. There's one from the National Comprehensive Cancer Network. There's one from Children's Oncology Group that reads very similarly. And it says all newly diagnosed cancer patients of childbearing age must be informed about potential loss of fertility and receive referrals to infertility specialists. So this was written 20 years ago. So this is not new. And really, I wanted to highlight that having these discussions is really the standard of care. And it really is on us as oncologists, as oncology systems, to really figure out how to do this. This is really, again, this is really a standard that we need to meet. And then a question is like, how are we doing nationally with getting AYAs consults with fertility preservation? I wish it was better. I will say that, I've been in the space now maybe 8 years, and I've certainly palpably felt the difference in those 8 years about how much more of an emphasis this is in trying to create systems. However, the data would say that about 50% of AYAs are still not getting a quality consult and given their fertility preservation options. And even for those 50 who maybe have that conversation, there's a lot of things we still need to do about, making it accessible, lowering the cost, and doing things like the Walgreens program are doing. I also want to note that there is an increased bias towards certain patient populations that are really important. One patient population that jumps out is brain tumors, and it's a very common malignancy in AYAs, CNS tumors, brain and spine tumors. And, a bias there is for a lot of those patients, they will never be cured, but the expectation is that they will live many decades. But that bias sometimes from oncologists says, well, if they're not curable, then, this isn't a conversation that they want to have. Another bias that we've seen in the literature and anecdotally I've seen as well is that, an AYA might not seem like they have a lot of means. And so the provider might, know that fertility preservation is an expensive thing and just doesn't want to further burden the patient. Well, again, anecdotally, but the data also bears this out, that patients want to have that discussion. And even if there is not a good fertility preservation option for them, which there usually is, they want to be able to have those discussions. They want to try to figure out ways to pay for their fertility preservation if it's available. So please just have that conversation. I was very honored a couple of years ago to help be part of this special edition, the Elephants&Tea Cancer and Fertility. And I really recommend you pick it up, not to read my piece. The 5 other pieces from patients were really moving. So there were stories from AYA survivors talking about their experience, and sometimes negative experiences or lack of experiences with having fertility preservation consults or conversations before therapy, and then also their perspective of having parenthood after they're done with cancer therapy. They're really powerful and really moving. But my piece as a clinician was to kind of talk about, why do we have this problem and what are the ways we can maybe solve it? And I gave sort of 5 reasons as to why fertility preservation consults don't happen as often as they should. I mentioned awkwardness. It is just still a thing when you're talking about family building and reproductive organs. And sometimes it's tricky for the medical community when that's not their focus. Bad timing, I've talked about that, where it's just the patient is just diagnosed with cancer, a bomb is dropped on them, and then we have to talk about this other thing, which is sometimes a little tricky and very forward thinking and a lot of logistics. It's a tough age. People even sometimes in their 30s might not be totally sure about their family building plans, and certainly in their 20s, their teens, or they might not have thought at all about what they want for family building intentions. And so it's tough to, especially in that context, to talk about that. Reason number 4, we as oncologists aren't trained in this. I'd say that this is changing a little bit, which is positive. We have a training program here at the University of Utah for our pediatric and adult oncology fellows. But that's pretty uncommon, and this is just something that's long overdue. And none of us need to be experts in this field, and that's one of the takeaways I really want you to have to do a good consult. But it is on us as an oncology community to understand the basics so we can provide that consult. And then the logistics and cost, I really hope, as our science progresses in oncofertility and oncology in general, I really hope that a lot of these issues become less and less of a problem, but they still are, unfortunately, in 2025. I really like this quote from Dr. Niederhuber, who's a former director of the NCI, and he makes this case. He says, access to healthcare will be a greater barrier, a greater determinant of cancer treatment failure than scientific advances. And another way of saying that is progress is as much about implementation as it is about invention. I'm going to talk about some really cool reproductive techniques, and there's a lot of science that still needs to be done, and a lot of really cool stuff. But also this talk is really about the basics, about having a conversation, about utilizing techniques that are very well established, that are not new. And so I think we, in oncofertility, we need to walk and chew gum at the same time. We need to advance the field, but we also just need to do the basics and get these AYAs their consults. Okay, so how do we cause infertility with cancer therapy? There's two parts of the brain, or sorry, two parts of the body that are responsible for our fertility and reproductive endocrinology. Part of the brain, the hypothalamus, the hypothalamic pituitary axis, is this part of the brain, sort of in the center of the brain, and it sends messages through hormones, through the endocrinology system down to the reproductive organs, whether you're talking about testes in males or ovaries in females. And so you can either injure the center in that brain, the hypothalamus or pituitary, or you can injure the testes or ovaries. And we do that through, cutting, poisoning, and burning, as we say colloquially in oncology. And I'm going to talk a little bit about, the aphorism, the dose makes the poison, and how to think about risk stratifying, how at risk somebody is for infertility. What I won't talk about today, which is super fascinating, super interesting, is really the pathophysiology behind what happens. Why do alkylators, why does cyclophosphamide, how does it injure the follicles, the immature eggs? How does it injure the spermatogonia cells? It's just sort of beyond the scope of this talk, but a lot of interesting science about how radiation and different chemotherapies affect that. And also, just as sort of a disclaimer that I wasn't going to talk a lot about this, but I'm happy to answer questions, is there's this whole big group of medicines now, immunotherapy or biologic therapy or targeted agents. And again, each one is really unique, and how it could potentially injure gonadal tissue. And with oncofertility and the research, it often is such a delayed understanding, because you're looking at outcomes that are years, if not decades, farther down. So we have to do a lot of extrapolation from other models, all to say that we don't know a ton about these, immunologic therapies. And each one might pose a little bit more of a different risk. I would say in general, we do think that they probably are less gonadotoxic than a lot of the cytotoxic therapies. And this is really important in adult medicine and epithelial cancers. We use a lot more of these immunologic agents than we do in pediatrics. So that is why also the risk stratification, I'll talk about this in adults, is a little bit more challenging and a little bit more nebulous than it is in pediatrics. So I want to show you a graphic that I think really demonstrates, this is for women in ovarian function. In a second, I want to define two terms, and they're on the right there: the acute ovarian failure. So what this means is that the ovary is just not working anymore after cancer therapy. Now, if you're pediatrics or prepubescent, that would mean that you never go through menses. You have acute ovarian failure, never had menses, you need hormones to help stimulate puberty and continue thereafter. Or if you're a 25-year-old and get diagnosed with cancer and you undergo therapies and your ovaries never turn back on, then that would be considered acute ovarian failure. That is different than primary or premature ovarian insufficiency, or POI. And that's where the ovaries just prematurely or early go into menopause. And so, and that's an important differentiation because, again, thinking back to that slide where I had that second red arrow, there are women that go through cancer therapy and their ovaries might have been injured, but they're still functioning enough to do some fertility preservation. And so they would not have acute ovarian failure. They would have, but they're just at risk for primary and premature ovarian insufficiency, but they still have an opportunity to do fertility preservation. So differentiating between those two things and if the therapy puts them at risk for one or the other is an important thing to think about when you're doing a consult. So to the graphic on the left, we have the number of follicles or like baby eggs. And on the bottom, we have age, so 10, 20, 30, 40. And so those two dotted lines in between there is what we'd call a reproductive window, or when a woman could get pregnant. So the arrow on the left is like maybe looks like maybe around age 14 or something. That's when they would go through puberty. And on the right, the other arrow is, around the age of 40. Well, what happens when a female gets chemotherapy? So in this graphic, we put the arrow at, say, 19. So at 19, we give chemotherapy, gonadotoxic chemotherapy, and you see there's a quick drop in the fertility right then, where a lot of follicles are damaged either by the chemotherapy in this case, or would it be radiation. But also appreciate the line afterwards. The trajectory of that line really takes a hard dive. And so that's where I think some education about what they're at risk for, but also in this case, there would still be a chance that we could do a little bit of fertility preservation after they have finished therapy, but they will not be able to, in this case, get pregnant in their late 20s or 30s. I'm not going to spend a lot of time on the charts, but I wanted to show you that these exist. In these charts, unfortunately, we have a lot better risk stratification for pediatrics, adolescents, like basically 21 and younger, as far as some of the therapies that will make them infertile compared to adults, for that reason that a lot of adults are using a lot of different therapies, hormone therapies, immunologics. And so that's just a challenge of doing consults for young adults. But I do want to just highlight a few things. We do have these risk stratifications that at least give us some general guidance as to how at risk they are. So on the left, you can see alkylators. That's like cyclophosphamide, ifosfamide, melphalan. Below that, you have a transplant, which is just a lot of chemotherapy. You have heavy metals, platins, cisplatin, carboplatin, and then radiation. And again, as you can see, this is a male chart. There's either radiating the testicles or the hypothalamus. And so and if you go across from left to right, you can see minimally increased, significantly, and higher increase. I'll say that even with pediatrics, I can tell you, and I work very closely with some of the people who help write these really great papers, a lot of this is hand wavy. The data is a little murky. So even in pediatrics, even when we know exactly how much cyclophosphamide or cyclophosphamide equivalent dose that they are going to be getting, it still is a sort of vague as to, oh, you're at high risk or medium risk or low risk. And so I think I just want to appreciate that, and especially for my, when we do consults for adults where it's even murkier, it doesn't have to be perfect to have that conversation. I want to emphasize that. They do the same thing for females. We have that guidance. And I just want to highlight there's this really nice paper, series of papers that came out from the European Survivorship Group, the PanCare Life Consortium, that gave some nice guidance for females, for males. And then they did it in their series also some ethical considerations of when you are consulting for fertility preservation. So really nice paper. And they have in there some charts that kind of give you some nice recommendations. So not just tell you kind of they're at this, they're low risk, medium risk, high risk, but also say these are the populations that you should consider an oocyte or egg freezing, and I'll talk more about that and the other options. This is another group you should consider for the ovarian tissue cryopreservation. I'll talk more about that. But all just to say that there are some guidelines out there. And then finally, again, this is for 21 and younger. So, but I just want you to know these are still somewhat helpful, and you can kind of roundabout use these. I think even in your 20s, they're not designed for that. But this data, these calculators, actually a couple calculators from the childhood cancer survivorship study. So they are using data on adults that are survivors of childhood cancer, and then looking back at their exposure for their cancer therapy. And then they built these nice calculators that can give you a sense and kind of risk stratify. So for instance, this acute ovarian failure, This is, you put in some information, their age, some basic about their therapy, whether they got a transplant, whether they had abdominal or pelvic radiation, how much chemotherapy or CED or how much cyclophosphamide equivalent they got, and then they'll kick out an actual number, percentage of acute ovarian failure. And then they have that same sort of calculator for a primary ovarian insufficiency or premature menopause, as we talked about. And again, they can do the same thing. You can put in some information and it can spit out sort of these percentages as you look. This is how, when they're 21 and older and they get to 40, this is their increased risk of having infertility or having early menopause and therefore infertility. So some nice tools out there. But I wanted to sum up like this sort of risk stratification by really differentiating between consulting with peds and adults and like the sort of trade-offs. And of course, it's a spectrum, not just peds or adults. In peds, we have a little bit better risk prediction tools, as I talked about, and these slides will go out and there's links so you can check them out. In adults, there's less known about toxicities with some of the newer agents, so it's a little bit harder to risk predict. In peds, they're maximally fertile. Now, everyone is on a spectrum just genetically about how fertile they are, and there's people that are more fertile, less fertile. So, but for an individual, they are maximally fertile in their mid to late teens. And then as adults, if you're 33-year-old female, like your fertility for you is less than it was as a teenager. So we have to sort of take that variable into account when we're talking through a consult. In peds, adolescents may not have thought through their future family goals, and maybe in adults you have the conversation, they've already thought through exactly what they wanted to plan for their family building, which is always nice. But if not, then you have that decision then. In peds, you have a caregiver decision making, which is always just a tricky on that conversation about parents, what do they want to do for their kids, or if it's a 14-year-old, the parents might be a big part of that conversation about helping their child make a decision about doing fertility preservation. And in adults, they might be making that decision by themselves, or they might have a partner to make that with. And I think one of the things that's really important for both populations, whether you're talking about peds or parents of a young family or an AYA, often financially constrained and very few are financially independent, keeping in mind in this country right now, greater than 70% of all people are living paycheck to paycheck. So when you're talking about having to, potentially write a check to cover fertility preservation, and there's not this time to like raise money, it's a real big issue. So let's talk about the fertility preservation options that we have. We'll start with males. For males, sperm banking. It is relatively cheap, hundreds of bucks, and it is effective, and that's the best option medically and cost-wise if we have it. If you have a post-pubescent male, so during puberty, the testicles kind of turn on their machinery and start to make sperm. For males that cannot ejaculate for one reason or another, or have very low sperm, there are procedures called testicular sperm extraction procedures where you can do the TESE or a TESA as an aspiration, or there's a surgery, a micro-TESE, which is what that picture is showing, where a urologist will actually bive out or sort of cut into the testicle, look, and then they see these like swollen tubules, which are more likely to contain sperm, and they can obtain sperm that way. It's costly. It's a surgery, but it's a good option for those who can't ejaculate or have a lot of sperm in their ejaculate. Then there's this other process called the testicular tissue cryopreservation. So this is for prepubescent boys who they are not yet making sperm, or for non-semen producing patients. And so what this is taking a sample of the testicular tissue. There's no sperm to be had, and then cryopreserving that. It is experimental, and this is a really exciting part of piece of medicine right now. We have been successful. Kyle Orwig and his team out in Pittsburgh has been successful with using this technique and creating a baby monkey. So that's Grady. The name comes from graft-derived baby. What happened in this case, they took a sample of testicular tissue. They sterilized the monkey, then they reimplanted that testicular tissue, sewed it back in, it got blood supply, then Kyle and his team go and actually retrieve sperm as the testicular tissue wakes up, and then combined it with a female egg from a rhesus monkey, created an embryo, and then this healthy monkey baby Grady. So we have not yet been successful in humans yet, but that research is undergoing, and it's going to be really game changing when that happens. So let's talk about females. It's a little bit more complicated, and unfortunately also just based on physiology and anatomy, more costly. So egg freezing, also known as oocyte cryopreservation, oocyte harvest, immediate controlled ovarian stimulation, random start controlled ovarian stimulation, it has all these names. And essentially there's two pieces. One is getting the ovaries to mature a lot of eggs, and then the second is to go obtain those eggs. So the way they stimulate the eggs, and this would be done by a reproductive endocrinologist, infertility doctor, an REI. They inject hormones. Unfortunately, these hormones cannot be taken orally. They have to be injected. They get broken down in the stomach otherwise. The injections for about 2 weeks. And what this does is, as you can see on the top right, with the blue line going across the natural cycle, where you have immature oocytes, the ovary will get one mature egg ready for every menstrual cycle. Well, if we're going to go in there and retrieve eggs, we'd like to retrieve a bunch of eggs. And so that's where the stimulation of those hormones for about a week and a half, 2 weeks comes in. Stimulates that ovary to get a lot of mature eggs ready. And then you can see on the just below that, that's an ultrasound of some mature eggs. And then the team would go in with an ultrasound, see those mature eggs, and then go and retrieve those with a needle. And they usually do it transvaginally. So that's the process. It's about 3 weeks. That's why I usually counsel patients. If we have 3 weeks, or I'm talking to their oncologist, they have 3 weeks between now and when they have to start chemotherapy. Then we can do this between getting into an REI, having a consult, and getting started on hormones, and then having that retrieval about 2.5 weeks later. What are the take homes on this? You can do it with an embryo if they had a partner and wanted to partner it with sperm at that time, or more commonly an oocyte or just egg cryopreservation. It's generally safe, low rate of complications generally. Takes about 3 weeks. There's daily injections, which is really safe. But it's costly. This is a very ballpark number, but about $15,000 per cycle if you're not using any other means to defray the cost, like Walgreens Heartbeat program, which helps cover about half that cost is through medicines, and half of it is the ultrasounds and the procedures. So there's a lot of, and at the end, I'll show you some resources to help reduce some of those costs, but it's very costly otherwise. I just want to make a mention that Lupron, the GnRH agonist. So these are basically medicines that tell the ovaries to kind of go to sleep. These are used to, there's some research, particularly in breast cancer, that maybe this helps protect the ovaries a little bit. They're kind of sleeping while they're getting chemotherapy, and maybe less chance that the chemotherapy is injurious to the ovaries. And it has a lot of indications for this, and it also can decrease some menstrual, like, sort of bleeding during chemotherapy. So it's a really great medicine. It's a really important one. But I think it's just very clear, as this practice statement committee from the American Reproductive Society states, is not meant to supplant fertility preservation. So it's just not potent enough to supplant fertility preservation. So yes, I recommend Lupron for a lot of patients, but that doesn't mean we shouldn't have a discussion about fertility preservation options. So that's egg harvesting. Now I want to talk about something called ovarian tissue cryopreservation, or OTC. So first of all, this is no longer considered experimental. The ARSM in 2019 declared that it's no longer experimental. It had been proven successful enough. And I want to talk about what this really is. This, instead of going and collecting eggs or oocytes, this is actually taking part of the ovary, or in pediatrics, sometimes we take the entire ovary because they're small, and they take the ovary and put it into strips and then cryopreserve it or freeze it. So then how you utilize this tissue, you then implant this tissue, you sew it back in. They typically have been doing this back into the pelvis, but there's thoughts of maybe it could be successful anywhere. And you sew it back into the patient later on when they desire to try to build a family. And then the tissue sort of wakes up, gets a blood supply, gets the hormones that are coming from the brain and saying, hey, we should be maturing eggs here. And then you go and stimulate that tissue, just like we showed before, and then retrieve eggs that way. Then you would combine that retrieved egg with sperm, make an embryo, and through IVF, make a baby. So what are the indications, or why would we use this, and what are the trade-offs? One, I'd say it's not as successful as oocyte cryopreservation. If you couldn't tell from those other steps, there's just places where we might fail. So egg freezing or oocyte freezing is definitely the preferred. This is the only option, though, for prepubescent patients, because prepubescent females are not maturing eggs, so you can't stimulate their ovaries to collect eggs. So this is the only option for prepubescent females if we are at high risk of causing them infertility. And then this is also an indication for post-pubescent women who don't have the 3 weeks to undergo oocyte cryopreservation. So they might have a cancer like a leukemia and might be too sick to wait 3 weeks before starting cancer therapy. This is a laparoscopic procedure, and in general, you can do this, have this surgery, and then start chemotherapy like that night or the next day. It's a good fertility preservation option for those patients. And is it costly? Yes, it's a surgery, and if insurance isn't covering it, then it's just really costly. So a little bit more on just the cost here. These are just a rundown of, and I've kind of talked about them a little bit. For females, it is more costly. The procedures are just more challenging and timely, and take more time. But the truth is, these are often prohibitive. These costs are often prohibitive for young adults or parents of young families. It's just they cannot write a check for $15,000. And so, and I've even had males who say, a couple $100 to sperm bank. They just can't afford that. And also keep in mind that this is the initial cost to get it, basically this tissue into the freezer. There's an ongoing cost of anywhere between, when they're talking sperm or eggs or ovarian tissue or testicular tissue, somewhere between $300 and $500 per year to keep it in that special storage. So there are thankfully a lot of great programs like Walgreens Heartbeat Program, Livestrong partners with different fertility clinics, Reunite. There are some out there that can really help, and I'll show you some resources and some links for that. But the truth is, like, I just wish we didn't need Walgreens Heartbeat Program. I just wish this was like an insurance covered this like they cover any other, place where cancer therapy injures an organ, and just treated it the same. But we're not there yet. We have a lot to go. And I think, really solidifying this point, this is Brooke Lee. Brooke Lee was a patient of ours at Huntsman Cancer Institute, was in her 20s, diagnosed with breast cancer. And she did not think she had fertility preservation coverage, and was heartbroken. And it turns out that her husband happened to work for the U. We had just passed for the University of Utah covering employees. I was really excited about. But when she heard about the idea that most patients don't have insurance coverage, and she was one of the very lucky ones, she actually came to the Hill to Utah State Legislature and testified on a bill. This was House Bill 192, which helped provide fertility preservation coverage for Medicaid patients in Utah. So I've been privileged to work on 2 bills and help co-author them with Joyce Renecki and some other teammates like Joe Letourneau that cover Medicaid patients in Utah and cover state employees in Utah, like teachers and firefighters and police officers. But I think her quote, she's so well-spoken, such an intelligent young woman, and she drove this point home beautifully. And she said, the most attention-grabbing consequence of chemotherapy for me is the lasting damage to my reproductive organs and fertility. Insurance coverage for fertility preservation was life-changing. And these are just some newspaper clippings of just some of our battles with our Utah State Legislature. And I was just really proud of our state that they came through in both bills. And this is a map of, a lot of the work that the Alliance for Fertility Preservation, I'll talk about in a second, and Joyce Renecki are leading across the country. And this is a map showing the green are states that have some fertility preservation coverage, so not perfect by any means. The white is no coverage. And then the other ones have active legislation going on. So this is really an issue that we need to solve on the big scale, but there's still a lot of work that we all can do individually with patients in the meantime. So, okay, this is, maybe I would argue the slide that I care most about, which is, I think that most of you would care about, is like, how do we go about an oncofertility consultation? And these are really the questions to answer that I wanted to make sure that you guys felt comfortable with. What is the risk for infertility? Again, first of all, the takeaway is you don't have to have a perfect risk assessment, because there is no perfect risk assessment, even in peds and in adults. There's a lot of hand wavy about low risk, medium risk, high risk, but the oncologist, the radiation oncologist, should be able to give you some prognostication, some sense of this is high risk for infertility, or this is none, or this is low. And even just with those very, again, nebulous kind of terms, that can really be all that the patient really needs to then help make the decision. And then with that, based on their gender and based on their age, then we talk about what fertility preservation options are there. How much time do they have before they start therapy? An important question. And 3 weeks is the number I'd like you to have in mind for our post-pubescent females. That's usually the time to get them referral to REI, to get the hormone started and have retrieval. And I'd also just put on there, I'm going to put a reference to, there's been some research to show in breast cancer patients, Dr. Letourneau, one of my partners out here, he's an REI, has had a couple papers on this, shown that patients who wait those 3 weeks, that they don't have any changes in outcome. So just make sure that your patient really can't wait those 3 weeks, because there's always this rush to get started on therapy. We as oncologists feel it, and we want to get started on therapy. We want to start killing those cancer cells. But the truth is, a lot of patients can really wait those 3 weeks for that egg harvest. Is there any concern for progression due to fertility preservation? Again, there's, like, I'd say some conflicting data on certain types of diseases, and really talk to the oncologist, whether it's like a hormone, it's a hormone sensitive breast cancer, or there's some brain tumor patients where there is some thought that hormone stimulation or just getting pregnant could cause some disease growth. But the truth is, it's very conflicted, and I just really encourage patients and advocates for patients like yourselves to really make sure that you're looking at the latest literature, and sometimes that needs to be just a second opinion. There's a story in Elephants&Tea in that periodical with one of the patients who dealt with this, and went for a second opinion and got a different answer. Who's the fertility preservation expert in your region? Where's the sperm bank? Who's the REI? Have a good relationship with them, just so you can call them and say, hey, I got a cancer patient. They need to be seen in the next 72 hours. They need to get going. This isn't something that they can just be on a wait list for a couple months. REI clinics are very busy. But usually the REI teams are really, and andrology, men's health, are all really excited to help these patients. Is there someone to help them navigate the financial assistance program, or is that you? Or at least get these links to patients themselves, so they can investigate, because it can really make a huge difference in the cost, and really be the difference in some cases about whether they do fertility preservation or not. And then what are their family building goals? This, fertility preservation isn't for everyone, medically or just based on preference, but the data is so clear that patients so value their cancer care, just to have the conversations whether they decide to do fertility preservation or not. So I just it's the best thing for patients, and it's all in our best interest, honestly, is just a cancer community to have these conversations. A couple of resources as I wrap up here. The NCCN, the National Comprehensive Cancer Network, they have some really great resources for both providers on the right and patients on the left, and they have some fertility stuff. And the Alliance for Fertility Preservation, Joyce Renecki is the executive director, a real hero in this space, has been leading this charge for years in helping get all that legislation coverage to get patients the ability to do this fertility preservation. Their website is also really helpful. They have a section of financial assistance programs. This is like a screenshot of some of the programs that can help defray the cost. So anyway, I encourage you to check out that website and to look in the financial assistance programs, and certainly bookmark that for your patients. The take-home points, this is just really important to patients, and they just really appreciate having the conversation, even if fertility preservation isn't for them right at this time. And there are challenges, as I enumerated. But please keep in mind, there are fertility preservation options for most. Patients want to hear their options. and there are organizations to help lower the cost. And you don't need to be an expert. You just need to make this a priority. I'll call your attention to one article that was out in the New York Times this summer that talked about women and breast cancer. And as you can see from the title, first a cancer diagnosis, then a split-second decision about fertility. And I thought they quoted and interviewed a lot of women, and I think they really captured the issue and the stress really well. So I call your attention there. And yeah, I think with that, I'll just wrap up and say thank you so much for your attention, for your interest in this area. Really thankful to all of our AYA patients who teach us so much and are an inspiration, to Elephants&tea for having me, Walgreens, and thank you, Lolly, and your team for all you guys do. And on the left is some of the knuckleheads I have at home, and my wonderful supportive wife, Corey. And on the right, the Oncofertility Consortium is this international meeting. It was held in Detroit this year. And so a lot of some pictures there of some of the teams I work on that work on research and clinical innovation in this space. And we had a great meeting a couple months ago, and have a lot of aspirational plans in 2025. So with that, I'll stop. Thank you so much for your attention.
Thank you, Doug. That was a phenomenal presentation on a topic that I know all of us care so much about and want to and need to do better for our patients. So Scott and I are going to ask some rapid fire questions, and we hope that you keep your response a little bit limited because we're running out of time. But just to hit the first one in the Q&A, what is the success rate of the OTC tissue procedure?
It's not to buck the question, but it's impossible to know because everything is just a retrospective data at this point. But there's been now hundreds of live births that have been the product of that. And we've even had a couple successful births from using prepubescent ovarian tissue. And so it is our backup option, but it is successful. I generally give a very hand-wavy 30% to patients, but that's sort of very hand wavy just to have them anchor on some number.
Then there was a question about if men are able to have hormonal suppressors to maintain fertility.
No, unfortunately, there isn't that Lupron analogous medicine. And again, Lupron is not a miracle worker, unfortunately, with that. So no, but I would say that with men, it's a little different. In women, when you go through menopause, you lose fertility and hormonal function, the two of them. With men, the cells that make hormones are different than the cells that make sperm, and the sperm making cells are a little bit more sensitive to chemotherapy. So men can often they'll lose fertility earlier or more likely than they lose hormonal function. With that said, it's important to screen for hormonal function and make sure men are not low on testosterone as well. And then there's men specialists, they're usually urologists that help treat those conditions.
Perfect. We're going to keep going. The questions are coming in hot. So next question is regarding outcomes in terms of any increased risk of cancer. I'll add any increased risk of birth defects for embryos that are reimplanted.
So we don't know. We don't think so. There's a nice paper that looked at a slightly higher risk of miscarriage among even like leukemia patients, which don't get a lot of gonadotoxic. So there might be, I think the one takeaway is if you are a cancer survivor of any cancer, especially if you're a little bit later, in late 30s as a female, it might be worth really seeing an OB that is really thoughtful and, sort of maybe considers you a little bit more high risk, even though we don't really know how to qualify that. But we don't have any evidence to say that like the follicles that do make it through chemotherapy, the ones that weren't injured enough, that they actually have increased rates of birth defects or abnormalities. So we don't think that is the case, and we probably would have seen that as an outcome. So
which patients do you recommend Lupron to? Is it about time, diagnosis, age, and also given the experimental status for that medication?
The Lupron, to be clear, isn't experimental. So apologies if I was confusing on that. And in general, there's not a lot of patients who we say that are post-pubescent. So post-pubescent females, it suppresses the ovaries, and so you stop having periods. There's not a lot of patients that there's contraindications, or meaning that they probably shouldn't get it. It also can just help with some menstrual bleeding that you can have when your platelets are low or going through chemotherapy. So I would say most post-pubescent females, we recommend that, and we start it ideally before they start their therapy. But if not, even if they've started chemotherapy, they can still do Lupron. So most patients.
Great. Combine two sort of questions together. One, is there a list of fertility support resources for patients we could maybe share with this group? And then if you could just comment on where patients would need to go to have frozen ovarian tissue reimplanted. Will local reproductive endocrinologists do this? Do you need to be at an academic center to have this done?
Yeah, it's a good question. So I think the nice thing about on the fertility preservation side, so not utilizing the tissue, but just having that oocyte or the egg freezing. The technology is not special between certain REIs, academic or otherwise. So in a lot of private practice are really great, and they're super good at doing this. They do this for so many females that are not cancer patients. It's usually the thing you just have to get a relationship with if you are just diagnosed, that time might be a little bit more of the essence, and so you want to get into them within days, or so that's the only usually issue. Otherwise, a private practice is super great, or academic place. And then as far as utilizing the tissue, yes, I mean, I would make sure I went to a bigger center, and places that store your tissue, they're just storing it. So it's your tissue. You can take it to wherever you want to have it reimplanted, or so I would, given it's I would just recommend probably a bigger center. The surgery is not terribly complicated, but it's sewing that tissue back in. But you're going to want to be really monitored by reproductive endocrinologists that kind of do this and think about this.
What about resource lists for patients? Are there sort of open lists in terms of resources that we can share with our providers so they have access to provide their patients? Anything that you know of or could share with the group?
I think that there are, I think on the resource list of how to defray costs and that sort of thing, the one from the Alliance for Fertility Preservation is really great. And then other resources, I would say that I think just talking to your oncology team, because again, unless you're talking about that specific case, you're talking about reimplanting ovarian tissue, a lot of these procedures for fertility preservation, or talking with, say, men's health or female health, if you have like low hormone or early menopause, that is really in the scope of practice of lots of REIs or frankly gynecologists. And so I think there's a lot of local expertise, and I think just going to your oncologist, see if they have a recommendation, or your local REI, reproductive endocrinology and fertility, and they are ubiquitous and all over the country.
I know we're at the end of time now, and I usually take up Kayla's spot and close too early. So we see there are additional questions in the chat. Please feel free to email Doug directly. He has not offered yet, but he's always very kind and responds quickly. But these questions are wonderful. This has been a wonderful session. Thank you guys for your attention. I will pass it off to Kayla in a second. I just want to personally thank Doug for a superior job, not just in this presentation, but all the advocacy work. It really makes such an impact for our patients and our community. So on that note, I will not thank Doug again in the future, and I will pass it off to Kayla.
Awesome. Thank you so much. I will have the pleasure of thanking Doug one more time. So truly, thank you from the Power team and for being a part of this. Obviously, we know that this topic is incredibly needed and incredibly interesting and valuable. So I have a feeling this won't be the last time that we will see you on one of these. So the questions were wonderful. Thank you to everyone for being here. An incredible, again, thank you to the team at Walgreens, to Lolly for being a part of it. I saw Rick and Khadija in the chat as well. So truly your partnership is incredibly valuable, and the work that you do for the patient community and providers as well. So just thank you so, so much. I want to do just 2 very quick housekeeping things for everybody. We really do value the feedback that we get from these presentations. So I dropped a link to a survey that if you could take a few minutes of your time to fill that out, we really look at everything and it does shape the content that we continue to put out to the community and to all of you. So that is in there. I am also incredibly excited to share that the next session, we have a very quick turnaround this time, is actually next week. So it is on February 5th at 2 p.m. Eastern time, right here again on Zoom. So please make sure you register. That is going to be about writing in the care of AYAs facing cancer with Dr. Vinayak Venkataraman. So I am incredibly excited about this one. We wanted to put a session that really focused on providers and how we care for ourselves in this space. And so taking a little bit of a different spin and focusing on us, especially kind of given the world and things that are going on, we want to make sure that we acknowledge our own mental health and how we are doing and coping. So it'll be a really great, wonderful session. So I will also drop the link for that as well. If you are not already signed up for our emails, you can do that online through our website to make sure you get all of the information, including the reminder that this session was recorded, and you will have access to that as well as the library of all our previous sessions as well. So thank you again so much for everybody for being here. Doug, Mike, Scott, that was an amazing discussion. And we hope to see everybody next week. So thanks all. Have a wonderful week.
Bye, everyone. Thanks, Doug.